Hello everyone, and in this video we are going to see about varicose veins, which is a very important aspect in clinical examination in surgery. So let's get started. Varicose veins are dilated, elongated, tortuous veins, superficial veins of lower limbs with reversal of flow or reflux with size being more than 3 millimeters. It is more common in age group of 45 to 70 years. It is more common in females, about 10 times more common than males. Now going to history. The patient may come with chief complaints of swelling along the veins or dilated veins in the lower limbs, or pain in the lower limb, or blackish pigmentation of the skin in the leg, or ulcer in the leg. Now coming to history of presenting illness, where we will elaborate each and every chief complaint in detail. First is swelling. We have to know for the onset, that is sudden as seen in deep vein thrombosis or insidious. We have to know the duration. We have to know site of onset and progression of the swelling. We have to know the aggravating and relieving factors, uh, whether it disappears on lying down or not. We have to know any pain or color change along the course of vein as seen in thrombophlebitis. Now coming to pain, we have to know the onset, whether it is sudden as seen in deep vein thrombosis or insidious. We have to know the character of pain. It is dull aching in varicose veins, while it is cramping pain in deep vein thrombosis. We have to know the mode of occurrence. On walking, that is intermittent claudications as seen with deep vein thrombosis, or towards the end of the day as seen in varicose veins. Now coming to ulcer, we have to know the onset, duration and site of the ulcer, associated pain, discharge and bleeding, itching, skin color changes, etc. Now going to past history, we have to inquire in detail about history of deep vein thrombosis, as in pain and swelling in the calf with fever, hospitalization, prolonged immobilization in bed. Now coming to personal history, we have to inquire for oral contraceptive pill intake, smoking, occupational prolonged standing for a long time, recent long air travel, which is a contributory factor to deep vein thrombosis, occupational long term sitting. Now coming to treatment history, we have to know whether any treatment was taken for history of surgery in lower limb, history of elastic compression, history of injection sclerotherapy, and the last is family history. We have to look for the similar illness in family. Now coming to examination. The first is inspection. We have to inspect or examine in standing position. Supine position is for special tests. We have to inspect the location of dilated veins. We have to inspect the affected venous system. The venous systems are greater saphenous system, which is in front of the medial malleolus, runs medially in the leg and thigh, and ends at saphenous opening. Short saphenous system is behind the lateral malleolus, runs posteriorly and terminates in the popliteal fossa. Perforators and both long and short saphenous systems. Now we have to inspect for the extent of involvement, skin of the leg, pigmentation, as in for pigmentation, eczema, ulcer, texture, color. There might be localized redness as seen in thrombophlebitis, generalized whiteness as seen in phlegmasia alba dolens due to edema and lymphatic obstruction. Blue and congested skin may be seen in phlegmasia cerulea dolens as seen with deep vein thrombosis. Continuing with inspection, there is Morris's test, which inspects cuff impulse at the saphenous opening. We have to also inspect for discrepancy in the limb size as seen with gigantism. Now coming to palpation. First we have to palpate for tenderness or thickening of the veins along the course. We have to palpate for the cuff impulse at saphenofemoral junction. Now coming to special tests, including first is Brody-Tendenberg's test to evaluate perforators and saphenofemoral wall respectively. In the first part, for perforators, we have to empty the veins, block the saphenofemoral junction by tourniquet, make the patient stand with tourniquet tight. Superficial veins get distended, indicating perforator insufficiency in case of a positive test. In second test or second part, we have to empty the veins, block the saphenofemoral junction by tourniquet, make patient stand, release the tourniquet. The superficial veins get filled quickly from above, indicating incompetence of saphenofemoral junction. Then coming to tourniquet test, we have to tie multiple tourniquets at the level of each known perforator. one above and one below. Then coming to Schwartz test, we have to tap the lower part of long saphenous system, and if the test is positive, impulse is felt at saphenous opening. Then Fagan's test, we can feel crescentric gap between the deep fascia at the site of perforator. Modified Perthes test, we have to block the saphenofemoral junction, walk for 3 to 5 minutes, evaluate the change in dilated superficial vein. If there is collapse, deep veins are patent. And if the veins become more distended and there is bursting pain, it indicates deep vein thrombosis. Now coming to Pratt's test. Elastic bandage from toe to groin is applied to empty the veins. Then you have to block the saphenofemoral junction by tourniquet. Then the bandage is taken off. Now the bandage is applied from groin to toes, and when we can see the blowouts at the site of perforators. Then we have to palpate for the ulcers. We have to palpate for arterial pulsations. The first is Brody-Tendenberg's test. Here is multiple tourniquet test. This is Fagan's test. This is Schwartz's test. This is Perthes test and modified Perthes tests. And this is Pratt's test. Now coming to last part of examination, which is auscultation. We can hear bruit in arteriovenous fistula. So that was all about varicose veins examination. I hope you liked the video. Please do like, share and subscribe to our channel, and don't forget to press the bell icon so that you will never miss an update. Thank you.